My name is student Dr. Irizarry, and you are?
Kane.
Kane. So, Mr. Kane, I'm going to be doing your physical exam today. Are you okay with that? Excellent. My hands are washed. I have my white coat on, and I have set a nice environment for my patient. So first, I'm going to start by asking my patient, do you know where we are today?
Yep.
Can you tell me?
Berry University.
Excellent. Do you know what day it is today?
Tuesday.
Awesome. So part of my general inspection is my patient is alert and oriented ×3. He does not appear to be in any respiratory distress. He's got good body habitus, good posture. He's maintaining eye contact, and I anticipate he will be a reliable historian for the history portion based on his communication. So next I'm going to start by taking the vitals, and I will start with the pulse first. So I'll set my timer. Taking over the radial. (15 × 4 is 60. Next would be respiration. (3 × 4 is 12, and that is normal. And now I'm going to follow that up by taking his blood pressure. So I'm going to align the BP cuff up with his brachial artery, about 2 inches above. Place that on nice. There we go. There's that stethoscope I need. All right, I'm going to listen with the bell. Excellent. It's not working. There we go. There we go. Operator error. Excellent. Bumping that up to about 160. I happen to know that you have an elevated pressure sometimes. (136/90). I would offer to take that in the second arm, but due to time constraints, we're just going to move forward. All right, so after the vitals, we'll start with the general survey. Again, my patient is in no apparent distress. He appears to be well-developed and well-nourished. And next, I will move on to the head exam. So I'm looking for any signs of trauma, any battle signs. I don't see any, so it appears to be normocephalic atraumatic. Moving on to the eyes, I'm inspecting the eyes, looking at the sclera for whiteness, avoiding any scleral icterus, looking at the conjunctiva, and I'll have you remove your glasses really quick for me. Thank you so much. Looking for redness, discharge, injection, of which I don't see. And so you can go ahead and put your glasses back on for me. I'm going to check gross visual acuity, and I'll have you cover one eye for me, please. And can you tell me how many numbers I'm holding up?
2.
Excellent. Can you cover your other eye for me? How many numbers am I holding
3.
up? Great. Now with both eyes?
4.
Excellent. So that would be for cranial nerve 2 for visual acuity. And then after that, we will check for direct to consensual light reflex. Cranial nerves 2 and 3. Direct, consensual, direct, and consensual, and pupils are equal, round, and reactive. Next, I will do the EOMs, cranial nerves 3, 4, and 6. So please look at my finger. Do not move your chin. Checking for signs of nystagmus and all of the EOMs and fluidity and symmetry with the eyes. Follow my finger in for convergence and accommodation. Look at my finger. Look at a point behind me. Look back at my finger. And so pupils are equal, round, reactive to light and accommodation, and EOMs are intact. After cranial nerves, I think that's it for the eyes. For the cranial nerve number 5, that would be the trigeminal nerve. So I'm going to have you clench your jaw for me, please. Feeling for the masseter muscle, for the temporalis muscle, and then again for the masseter muscle. Go ahead and open your mouth for me. This would be for the TMJ. Excellent. Feeling for any clicking or popping. And then also then for cranial nerve number 7, I'll have you raise your eyebrows for me and blow out your cheeks. Excellent. So the face is symmetrical. I'm palpating the frontal and the maxillary sinuses. Next, I'm going to move on to the ears. I want you to close your eyes for me and tell me which side you might hear something.
No.
Excellent.
Right.
Wonderful. So that would be the finger rub test for cranial nerve number 8. I'm going to palpate the pinna, the lobules, and the tragus, noting for any signs of tenderness on my patient. Next, going to do the otoscopic exam, holding the otoscope in proper fashion, pulling the pinna back, looking at the external ear canal, looking for any discharge, any foreign bodies. Looking at the TM, I recognize the cone of light. The TM is pearly gray, and it has not bulging, and there is no exudate, and it is not, has no barotrauma. And I'll do the same on the other side. Excellent. Okay, that completes the otoscopic exam. Next would be then to do cranial nerves number 9 and 10. Pardon me, sorry. 9 and 10. And that will be the palate. So I'll have you open your mouth nice and wide for me, please. Excellent. So I'm looking at the buccal mucosa, noting for any lesions. Put this right on your tongue. Say ah for me.
Ah.
Excellent. So I'm looking, you have very generous tonsils, honestly. Okay. And no exudate, and no erythema, no postnasal drip. I looked at the rise and fall of the uvula. It was symmetrical, so that would imply that cranial nerves 9 and 10 are intact. 10 could also be a gag reflex, but I will spare you. And then after that would be cranial nerve number 12, hypoglossal. Go ahead and stick out your tongue for me, please. Looking for any atrophy, any fasciculations. It's symmetrical and does not deviate to either side. Cranial nerve number 11, which would be spinal accessory. I want you to oppose my force against your chin, so turn into my hand. Excellent. Excellent. So I'm checking the integrity of the SCM, and then shrug against my hand. And so that would be the shoulder shrug for cranial nerve 11. And that should complete HEENT. Next would then be moving on to the neck and looking at the anterior neck at the soft tissue, looking for any signs of swelling or any deformity, of which I do not see. I'm going to palpate the patient's lymph nodes. I'm going to start with the occipital, postauricular, preauricular, tonsillar, the angle of the jaw, submandibular, submental, posterior cervical chain, posterior to the SCM, anterior cervical chain, deep cervical one at a time, pull it forward, feel in that deep cervical canal. Next side, pull forward, excellent. Supraclavicular and infraclavicular. Next, I'm going to then auscultate for and palpate then for the carotid artery. All right. I'm going to start with Brewy with the bell. Hold your breath for me, please. You can breathe. And I'm palpating. All right, excellent. Hold your breath for me, please. And then I'm palpating. Excellent. Yeah, I don't hear any bruits there in the neck. Okay, so ready to move on to the pulmonary exam. So I'm looking at my patient's AP diameter. It should be 2 to 1. He does not appear to have a barrel chest. I'm going to start with palpating the chest wall, really paying attention toward the costal margin. Excellent, for any tenderness. Now I could do thoracic expansion either anteriorly or posteriorly, so take a deep breath for me. Excellent. And I'll demonstrate it back here for those in the back. For symmetrical chest expansion, take a deep breath. Wonderful. Next, we're going to do tactile fremitus. So each time my hands touch your back, I want you to say the number 99.
99, 99, 99, 99, 99.
Excellent. Hands on your hips, please. Perfect.
99, 99, 99, 99.
Great. So I'm feeling for increased vocal resonance, of which I do not palpate. Next, we're going to then percuss the lung fields, and we'll start at the apices. Hands on your hips, please. Listening for resonant tones in the anterior, lateral, and posterior. So I'll have you hold your elbows, please. Excellent. Ladder pattern. Excellent. I hear no dullness, no signs of consolidation, which is wonderful. So now I'm going to auscultate in the exact areas that I just percussed. And I'll have you breathe in and out of your mouth. I'm gonna listen with the diaphragm. There you go. Starting at the apices above the clavicle. Great, so I've currently listened in 6 spots, and now I'm gonna demonstrate where I would listen to Darwin's chest. Hands on your hips, please. And again, they are in the exact same areas that I just percussed. I'm coming around to your back, please. And I'm only coming around to this side. Please stay on the right side, but I'm coming around because the majority of you are sitting over here, so please stay on your patient's right side. Excellent. Now I'm going to ask that each time my stethoscope touches your skin, I want you to say the letter E.
E, 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 E.
And I would repeat that in all of the lung fields, anterior, posterior, and lateral. You can choose bronchophony, egophony, or whispered pectoriloquy, all of which. Now that is for increased vocal resonance, of which I do not see or hear, excuse me, and I'm listening for the E to A change of egophony, which I don't appreciate in this patient. All right, so next we are going to move on to the cardiac exam. So I'm gonna have you scoot all the way back and lay back. And I'm inspecting my patient's neck for any JVD at this 30-degree angle, of which he does not have any JVD. I'm going to palpate his pulses. So I'm going to start with bilateral brachial pulses. Excellent. I'll have you put it. Awesome. Thank you. Good. They are symmetrical, 2+. Excellent. So brachial, radial, dorsalis pedis. Oh, great, awesome, you've got great pulses, excellent. And then the tibialis posterior. Wonderful. With my patient still laying recumbent, I'm going to place my hand right on his chest wall, and I'm going to palpate for lifts and heaves. Also focusing on each of the valves, feeling for thrills, and the PMI, in the 5th intercostal space, mid-clavicular line. Okay. So I'm going to listen to my patient. Just keep them in this position. I'm going to start with the diaphragm for the high-pitched tones of systolic sounds. I'm listening for clicks, murmurs, and gallops over the aortic in the right, 2nd intercostal space, pulmonic, left, 2nd intercostal space, 3, 4, tricuspid, 4th intercostal space, 5, in the PMI over the mitral valve. Excellent. And now I'm going to listen in that same order with the bell for lower pitched tones of diastolic rumbles, aortic, pulmonic, Erb's point, tricuspid, and mitral. Excellent. Wonderful. So when my patient is laying recumbent, I'm going to start inspecting his abdomen, looking at the contour, looking for visible signs of peristalsis or any notable bruising or any surgical changes. I'm going to begin the abdominal exam by listening. I'm going to listen with the diaphragm for bowel sounds in all 4 quadrants. Excellent. Then I'm going to switch to my bell and listen for bruits over the abdominal aorta. Just above the umbilicus on either side for the renal, and then for the iliac just below the umbilicus on either side, which I do not hear anything. And then going to move forward into percussion of the abdomen. Gastric air bubble, tympanic changes, normal for the abdomen. Excellent. Then I'm going to start with a gentle palpation so I can understand his anatomy. Feeling for that liver border. Looking for any signs of guarding or rebound or any peritoneal signs of rigid abdomen. And I'm going to do a deeper palpation. Excellent. Feel for that again, that liver border right here. See if I can capture the spleen, capture the kidney. Feel in that lower GI area on that left side, right side over McBurney's point. Awesome. Okay. And that would be it for the abdomen. Moving on to the musculoskeletal, I'll have you go ahead and sit up for me, please. And I'll have you scoot all the way down. So we're going to start with your neck, and we're going to go through different ranges of motion, and then I'm going to challenge you for muscle strength after we're done with that. So I want you to kind of do what I do, lift your head all the way up. Perfect. Put your chin to your chest. Wonderful. Head back to center, ear on your shoulder. Oh, that felt good. That way too. Wonderful. And then chin over your shoulder. Okay, wonderful. Now I want you to oppose my force. Push against me. Forward. Awesome. Back to the side. Excellent. Side. And I already checked chin when I checked cranial nerve 11 for SCM strength. So you can repeat it there if you would like. I'm going to move on to the shoulders first. So I want you to do the full extension all the way up. Excellent. And then full, well, that was flexion, full extension. Excellent. And then abduction. And then adduction. And then hands up for external rotation and internal rotation. And I'm going to challenge your muscle strength for that. And again, when I'm looking at all of the joints, I'm looking for any deformities, any swelling, erythema, or any asymmetry. So push against my force out, and then back in, and then push forward, and then back, and then internal and external rotation. Actually, I'm going to have you hold your hands like this. Push against my force in. Excellent. And now out. Perfect. Now would be for external. Moving on to the elbow, inspecting the elbow for any changes. We'll do full range of motion, complete elbow flexion and extension. Right, and then at a 90-degree angle, let's do bicep strength and then tricep strength. Excellent. And then coming down, looking at the bones of the wrists and the carpals. And I want you to do flexion and then hyperextension. Great. And then we'll do the ulnar deviation, radial deviation, and then oppose my force. Go up and go down and out. And then in. Excellent. Same concept. Usually can only do this one side at a time. In and then out. Wonderful. Spread your fingers out. Close your thumb. Wonderful. So I want you to grip my hands. Full on hand grip. Grip tight, 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 tight. Excellent. And then hold your finger and your thumb together and don't let me pull it apart. Making sure there's integrity there. Okay, awesome. Moving on to the back with while you're sitting, I'm going to have you first turn. We're going to do a rotation, and I'm going to sit right here. Bring this shoulder toward me and rotate your back. Wonderful. And do the same thing on the other side. Perfect. And then oppose my force. Wonderful. And oppose my force this way. Great. So now I'm going to have you go ahead and stand up. And I'm going to turn and I'm going to stand behind my patient. I want you to stand right here. And I'm going to stand right behind him for the forward bend test. So go ahead and bend forward as far as you can, looking for the alignment of the spine. Wonderful. And then come back and then do a hyperextension. Wonderful. Great. And then slide this arm down your thigh. Excellent. And then again on this side. Perfect. And that'll be it for muscle strength there. As for the hip, now you can go ahead and turn around. If you feel comfortable standing, can you flex your hip and your knee all the way? And you can use the table for balance if you would like. Excellent. Flexion and go ahead. And of the other side too. Flexion and extension of the knee. Now to finish extension of the hip, turn this way and pull this hip back behind you. Excellent. Full extension. And then this one as well. Excellent. And then I want you to go ahead and abduct your hip. And then cross it over your body for adduction. Adduction. Okay. Adduction. Wonderful. The only muscle strength I'm going to do with you standing up will be the extension. So push against my force this way. Excellent. Good. And then this way too. All right. And I'm going to have you take a seat and we'll finish muscle strength. And so, yeah, there we go. So for flexion, go ahead and push against my force, push against my force, and then grabbing at the knee, push against my force. Excellent. And because we already checked range of motion of the knee, I'm going to finish with muscle strength down here at the calf. So push against my force for quad and ham. Wonderful. Next would be for dorsiflexion. So point your toes up toward the ceiling, down toward the ground. Bring the heels together. Excellent. And turn them out. And so push against my force for dorsiflexion and plantar flexion, and that should be it there. The next thing we'll do will be the DTRs. If you have time to do them bilaterally, great. If you only have time to do it on one side, that's fine too. My patient make a muscle, so this will be for bicep. Awesome. bicep, and I'll see if I can just get your tricep this way. So the tricep can be done this way. It can also be done this way. And since Darwin's been my patient before, I'm already aware of his cantankerous tricep. Oh, there we go. We got it. We got it. Okay. And then the biceps radialis. Excellent. Perfect. And then the patellar. Woo! And then the Achilles. Awesome. So again, if you have time, you could do that bilaterally. Was that everything? Did I get it all?
Yeah.
Okay. And what was my timing like?
20.
About 20. Okay. All right.